This recording will cover stem cell transplant. In a patient with leukemia, the patient's bone marrow isn't functioning properly, so it's producing non-functional white blood cells, and the overcrowding decreases red blood cell and platelet production. And one of the treatments can be basically to reset the bone marrow, and that can be done through a stem cell transplant. A stem cell transplant is essentially reintroducing healthy stem cells after the non-functional bone marrow has been eliminated. The goal is to restore normal blood cell production. There are three main sources of stem cells. Each one has a different collection method and outcomes, and they differ on how fast engraftment happens with them. First up is peripheral blood stem cells. This is the most commonly used method. Stem cells are collected through apheresis, which is similar to dialysis. With apheresis, the blood is drawn, stem cells are separated out, and then the blood is returned to the donor. And then we have the stem cells to give to the patient. The donor can be prepared by being provided growth factors that actually push more stem cells into the bloodstream prior to peripheral collection. Clinical consideration for this peripheral blood stem collection is that it allows for faster engraftment compared to other sources. And therefore, it's the most frequently used method currently. A memory tip would be to think peripheral is preferred. Other sources for stem cell donation include bone marrow and cord blood. With bone marrow, the stem cells are collected, the bone marrow is collected from the iliac crest. It's a more invasive procedure and results in slower engraftment. And then umbilical cord, the blood with the stem cells is collected at birth and stored. There's a lower risk of rejection with that, but there are fewer cells and slower engraftment. Before transplant, we have to prepare the body, and this is called conditioning. The purpose of conditioning is to destroy diseased cells and to suppress the immune system so that it doesn't reject the new cells that it's going to receive. This can cause severe pancytopenia, where patients are extremely vulnerable because their white blood cells, red blood cells, and platelet counts become so low. The conditioning regimen includes high-dose chemo with or without radiation, and in addition to severe pancytopenia, the patient may experience mucositis, nausea, diarrhea. Again, they're at increased risk for infection, increased risk for bleeding. This is when the patients are going to be feeling really sick. After conditioning, we've wiped out the patient's own bone marrow, thus preparing them for replacement with a new immune system. We move on to the actual transplantation. The transplant itself is simple. It's similar to a blood transfusion. There's no surgery. The cells are infused into the patient and they find their way to the bone marrow on their own. After that, we wait for engraftment. Engraftment is when the new cells start working. First, we'll see an increase in neutrophils, then platelets and red blood cells. So the big thing is when we're monitoring labs after stem cell transplant, an increase in neutrophils would be a good sign. It's important to remember that protection from infection during this stage is really important because we've wiped out the patient's immune system. Basically, we wiped out the bone marrow. So until engraftment occurs, the patient's at a really high risk for infection. There's three complications from stem cell transplants that we're going to discuss. The first one is graft failure. This happens when the transplant doesn't work. The bone marrow doesn't start producing new cells. You don't see an improvement in the CBC. You have continued pancytopenia with the red blood cell, white blood cell, and platelets all being low. Nursing priorities for this patient would be infection prevention and transfusion support. It's important to know that if those cells don't engraft, so if there's no engraftment and the new stem cells don't produce new cells for the patient, remember when we prepared the patient, we wiped out their own bone marrow. So if the transplanted cells fail to engraft, the patient will die unless another stem cell procedure is successful. So if there's no engraftment, there would not be survival without additional interventions. The second complication is graft versus host disease. This is when the donor immune system attacks the patient's body. So graft being the donor versus host, the recipient. The donor immune system attacks the patient's body. Signs and symptoms that we could see. A rash is often the first visible manifestation of graft versus host disease. We could see diarrhea, nausea, abdominal cramping, liver problems, jaundice, elevated liver enzymes. Treatment for this would be immunosuppressants like steroids or cyclosporine. Remember, with graft versus host, it's the graft attacking the host. So the donor immune system attacking the recipient. Our third complication is sinusoidal obstructive syndrome. This is a serious liver complication after high-dose chemo. Basically, what happens is there's blockage of liver blood vessels following high-dose conditioning, which impairs hepatic circulation and function. So signs and symptoms that we'll watch for: rapid weight gain, ascites, hepatomegaly or large liver, jaundice, the yellowing of the skin. Nursing actions include getting our daily weights, which is a top priority, monitoring abdominal girth, monitoring our liver labs, and then managing fluid balance carefully. Remember, if a patient suddenly gains weight, we're going to worry about sinusoidal obstructive syndrome. And just a reminder for your patient getting a stem cell transplant, we've wiped out their own immune system. So they're at really high risk for infection. So we're going to use neutropenic precautions, private room, HEPA filters, strict hand hygiene, no fresh flowers or raw foods, depending on your source. Limiting visitors, PPE. We're going to be monitoring the temperature frequently. Remember, with neutropenic patients or patients whose immune systems aren't functioning properly, just small changes in temperature, a temperature above 100.4, a change of 1 degree Fahrenheit needs to be reported, and we need to act upon those. We don't want to delay antibiotics with this population. Lastly, bleeding precautions. Because of the low platelets, we're at increased risk for hemorrhage. Avoid any invasive procedures. Use a soft toothbrush, avoid razors, make sure we implement fall precautions. Infection is the #1 cause of death in these patients. These patients need a lot of support while waiting for engraftment. So we've wiped out their bone marrow and we're waiting for the new stem cells to sort of take hold in their bones. Things that you might see ordered for the patient include blood products, red blood cells, platelets, can manage severe pancytopenia while we're waiting. Nutritional supplements, the patient might need TPN because of mucositis, as well as oral care for the mucositis. So gentle mouth rinses, remember we avoid anything harsh, alcohol-based mouthwash, assessing oral mucosa regularly for breakdown, and we're also looking at it for infection because remember, preventing infection is very important during this stage. Basically, the supportive care helps to keep patients alive while we wait for the transplant to work. So let's review some important points. In terms of stem cell donation, peripheral donation is the most common. It has the fastest engraftment results. Watching for an increase in neutrophils after stem cell transplant is important. That's the earliest indicator that the transplanted cells have successfully started producing new blood cells. Graft versus host, that is the donor immune system attacking the patient. We'll treat that with immunosuppressants. Rapid weight gain could signal the complication of sinusoidal obstructive syndrome, a liver complication after stem cell transplant. So be watching your patient's weight. And finally, the biggest risk for these patients, we've wiped out their bone marrow, is a risk for infection, and that's our top nursing priority during the transplant and engraftment period. Another complication that's worth mentioning is graft failure. That's when basically the transplant doesn't take, the patient continues to have pancytopenia, and they're going to need another transplant to see if they can get basically a new immune system, a new bone marrow system in place that produces effective, healthy white blood cells, red blood cells, and platelets. And with infection, remembering we're watching for fever, even low fevers in a neutropenic patient, that's considered an emergency.